Good? Y'all can nod. Okay, thanks. All right, so today I thought we would diverge a little bit from our conventional talks on medications, treatment of Parkinson's disease, motor symptoms, non-motor symptoms, a few of these talks that I've done in the past, and actually talk about a really interesting topic that has not been discussed formally, at least in these forums, but it always comes up in my clinic. So the reason I chose this topic is there's always a backstory. And the backstory was I was seeing a gentleman who I diagnosed with Parkinson's disease. You know, it was a very logical question. At the second or third appointment, he asked me, well, what's my prognosis? And before I started to talk, he said, well, please don't tell me, like I've been told by my previous neurologist, that everyone's Parkinson's is different and yada, yada, yada. I've heard that story before, everyone's a snowflake and blah, blah, blah. But I am pretty sure that of the millions of people with Parkinson's disease in the world, there've gotta be similarities, there've gotta be clusters. So what cluster do I belong to? You know, that's what I wanna know. So I was taken aback a little bit because I was actually going to tell him that everyone's Parkinson's is different and it's very difficult to prognosticate. But I sort of sat back and I thought, well, he makes a really valid point. There are similarities. Are there clusters? Can we subtype? Can we talk about, before we talk about prognosis, can we personalize treatments even more than we are? Can we do population health in Parkinson's disease? Because we all know it's Parkinson's disease because it is similar in so many respects, but at the same time, it's different in different people. So, you know, we talked about that a little bit and about the limitations of subtyping Parkinson's disease. And he was satisfied with some of the responses, but that led me to do this research on what are the subtypes, what research has been done, et cetera, et cetera. So I thought we'd talk about that briefly. It's a very brief overview of a very important a topic that is being researched extensively to the point there are about 2,000, 3,000, 4,000 journal articles on it. I tried to review as many as I could for this topic, and I basically did reviewed review articles instead of original research articles because, you know, they capture the research. So I reviewed about 30 journal articles from 2005 to 2020 for this talk. I didn't want to go before 2005 because you want to stay current with research and with review articles. But if you go before 2005, there are articles going back to the 19th century. In fact, the whole subtyping was very first done by Dr. James Parkinson, who recognized similar features in a group of his patients, which was later called Parkinson's disease. So it's been done for more than 2 centuries now, but not in any formal data-driven manner. And that's what we want to get to, so we can customize treatment. The largest biomarker program in the US, and I think we've all heard about it in some way or the other, is the one that's sponsored by Michael J. Fox Foundation, is the Parkinson's Progression Markers Initiative, or PPMI, and they come out with a paper every couple of weeks, because they have so much data now that they can actually analyze that data and talk about biomarkers in Parkinson's disease, which will allow us to cluster Parkinson's disease into subtypes, but also to see if there are differences in the different subtypes, which will allow us to design treatments differently for these different subtypes. So fundamentally, what is a subtype? A Parkinson's disease subtype is a group of individuals with Parkinson's disease with similar clinical and pathological features. The "and" is italicized because it's easy to cluster with respect to clinical features, but there could be really fundamental difference in physiological mechanisms and pathological mechanisms in the brain, which are relevant, particularly when you're trying to design different kinds of treatments. And we will see that in just a bit. So why are these Parkinson's disease subtypes relevant? We got to standardize research. We've had so many failed trials in Parkinson's disease because perhaps the population is extremely heterogeneous, although everyone in the population has Parkinson's disease. And therefore, that one outcome measure that is being measured is probably not relevant to every individual in the group. And so therefore, perhaps we need to split Parkinson's disease into its relevant subtypes and then design research for each subtypes. And potentially, we may be able to see a signal that we missed when we clustered a whole bunch of people together, even though in every research article, there are very similar demographics between the treatment group and the control group. We all see that 60% males in treatment, 60% in, the control, and then 80% white, 80% white in control and in research arms, and then the levodopa equivalent is essentially equal in both. So what we are basically trying to do is randomize and make sure that the baseline of both groups is as common as possible so the outcome can be measured. If you start with different baselines, then you don't know if the outcome is valid or not. But despite that, we've had a lot of failures. So perhaps that way of classification based purely on the clinical and demographic features is not enough, because pathologically, those individuals in those two groups could still be very different. So we need to subtype to standardized research, which will allow us to customize treatment, and then which may allow us to optimize treatment outcomes. And we already know this in a lot of other fields: diabetes, heart disease, epilepsy. There are certain ethnic groups that have been subtyped whose livers do not process medicine, certain kinds of medicine. And so therefore, now we know not to give that medicine to that particular subtype of individuals, although they may all have diabetes, or they may have epilepsy or heart disease. So what works for one cluster may not work for another. Okay, so that's why it's important to try to see if we can subtype to optimize treatment outcomes. How do you determine a Parkinson's disease subtype? Well, you have to take a whole bunch of people, like the PPMI is doing, characterize it, classify Parkinson's disease subjects over a period of time based on multiple factors and multiple domains, not just age or gender or ethnicity, but many things, and then basically do an analysis to see if there are groups of individuals that cluster into certain groups based upon some fundamental physiological differences. So currently we are classifying Parkinson's disease subtypes by motor features because that's the most obvious thing. And the two most common subtypes we see in Parkinson's disease are people without tremor, and people with tremor. The group without tremor is most commonly called PIGD, or postural instability and gait disturbance. In this particular subtype, people have problems with walking, they have axial problems and balance problems, but really no tremor whatsoever. And then you've got the tremor predominant Parkinson's disease subtype. And we will see why these two particular subtypes, although artificial and although not perfect, are somewhat relevant with respect to treatment outcomes. And it is important to recognize that up to 30% of people with Parkinson's disease may not have a tremor. So although tremor is by far very common in about 70%, 30% of the people may not have tremor with Parkinson's disease. How about age of onset? And because I thought this would be relevant to this group because there is an amalgam of early onset, Parkinson's, young onset, late onset, maybe middle onset, and we'll see how age of onset is relevant in subtyping Parkinson's disease. Genetics, and I'll have about 2 or 3 slides on genetics, very important. The overarching issue is a genetic mutation, regardless of the age, regardless of the gender, regardless of the phenotype. And that becomes really relevant because that genetic classification basically trumps or surpasses all of those other things. It's really fundamental that people are grouped via genetics, even if their ages are different. And then finally, data-driven biomarkers. Data-driven biomarkers, and we'll see in a little bit, that's probably towards the end of the presentation, is what PPMI is researching currently. So we talked about tremor predominant and postural instability and gait-predominant Parkinson's disease. In tremor-predominant Parkinson's disease, tremor is obviously more common. PIGD tremor is less common. It is thought that people with tremor in Parkinson's disease have a more benign course than people with postural instability gait predominance, or PIGD. There was a lower incidence of dementia in tremor predominant compared to PIGD. There are fewer balance problems in tremor predominant than in PIGD. And with respect to treatment, anticholinergic medications such as Artane or trihexyphenidyl, which we use with significant caution in a majority of the people, are much well tolerated in tremor predominant than in PIGD. So if we know that someone has a PIGD phenotype, and that's so easy to determine, you look at the patient, they don't have a tremor, they got Parkinson's disease, they've got the PIGD phenotype, you try to avoid anticholinergic medications because as a group, they're not very well tolerated. So that's really important. Now, deep brain stimulation, which is, the gold standard for surgical treatment, works really well to reduce tremor. And it was designed to reduce tremor. But unfortunately, deep brain stimulation does not work as well to improve balance, if indeed balance is the primary Parkinsonian disability or, the problem. So when we are counseling people who want to have deep brain stimulation, and they don't have a tremor and they have gait and balance problems, we counsel them differently than we do with people who have tremor. We tell them, listen, this is going to improve your stiffness and your slowness, but likely may not improve walking and balance. It does improve DBS, and I should have put that in here, motor fluctuations, wearing off, and dyskinesias. That works really well in both groups. So that was just a brief synopsis on the motor features. Again, very arbitrary. It's not a data-driven or biomarker-driven, so we don't use it very often in research these days, but it really helps with treatment. How about age of onset? So this is again very arbitrary. There is no proper classification. Every 10 years, there's a generational shift. Back in 1980, David Marsden said, oh, less than 30 is young onset. Everything over 30 is late onset. Well, in 2020, when the life expectancy is 85 years in the US, this is what we believe is a proper classification. 18 to 20, juvenile onset. 20 to 40 and 41 to 60 are young onset and middle onset Parkinson's disease, and over 60, greater than 60 to 70 is late onset. This is age. There's obviously an overlap. It's a bell curve. These are not discrete, this is not discrete data. So there is going to be overlap, but we still need some kind of a pattern with respect to age. And this is what people have come up with, researchers have come up with based upon the progression of the disease, and based upon genetics, which we will see in just a bit. So the young onset and middle onset are more similar to each other than the late onset Parkinson's disease. So this column over here, which is a middle onset, is more of a transitional column when people are transitioning from young to late. So what goes into this column is usually things that are basically carryover from young onset. So I didn't put anything in here because this is more of a transitional state. Nonetheless, MOPD is similar to YOPD in many respects. Now, these domains that you see on the left side are again very arbitrary, but they are important. They're important for the clinician with respect to treatment, with respect to focusing on what is the disability in each group. And these are very self-explanatory. When you have young onset Parkinson's disease, and when you're very young, and it depends on when you've gone to school, you're in college, you're employed. If you're a family guy, you got younger children. So that is important to keep in mind when you're treating someone with young onset Parkinson's disease. Late onset Parkinson's disease, most people are retired, they're independent, children are out of the house, etc. And we will see why that's important in just a bit. Interestingly, mood disorder is significantly more common in young onset than in late onset. Depression, anxiety, apathy, and impulsiveness is seen significantly more in young onset than in late onset Parkinson's disease. There are other psychological domains that are more common in young onset than in late onset Parkinson's disease. panic disorder, social anxiety disorder, acute adjustment disorders, substance abuse, family and social difficulty due to Parkinson's disease. And it is important to recognize that these are correlations, not causations. Okay, it's just that we see it. Is it because of Parkinson's disease, because of the diagnosis, or what have you? Or is there truly a neuropsychological difference in people with young onset Parkinson's disease than in late onset Parkinson's disease? Scientists would say that yes, there likely is, because young onset Parkinson's disease behaves differently than late onset Parkinson's disease. As a result of these domains that we've discussed, the social, psychological, economic impact of young onset Parkinson's disease is more severe. Well, if you're young, you're employed, you got children, and some are going to college, etc., and you have Parkinson's disease and it robs you of your employment, etc., you can understand that the economic impact, the social impact is going to be significant. And I see this on a regular basis in my clinic. So a lot of the stuff that I'm presenting is based upon evidence, but also empirical observations that I've had for the past 12 to 15 years. And what about motor symptoms in young onset versus late onset Parkinson's disease? Because of the genetic propensity in young onset, we see more stiffness, slowness, and dystonia in young onset Parkinson's disease, whereas we see more tremor in late onset Parkinson's disease. Young onset Parkinson's disease individuals are more prone to early motor fluctuations and early dyskinesias after treatment. The incidence of dyskinesias decreases with every 10 years of increasing of age over age 60, and this was shown by the Mayo Clinic researchers. So there is overall a lower incidence of dystonia and dyskinesia in late onset Parkinson's disease. And it is important to remember, we are not talking about duration of disease. We are talking about age of onset. So when I say age of onset, I'm talking about onset at age 60, onset at age 70, symptoms starting at age 80, not the duration of the disease. This is, again, very important, and I commonly see in my clinic pain related to Parkinson's disease without any other disorders is significantly more severe in young onset than in late onset. But pain related to neuropathy and orthopedic condition, hip conditions, knee conditions, ankle conditions is significantly more common in the LOPD group. And this just harkens back to the lecture I gave a couple, 2-3 months ago on pain, in which we talked about different kinds of pain in Parkinson's disease, pain directly related to Parkinson's disease versus pain in Parkinson's disease from other causes. What about the other domains? Now, these are non-motor and motor symptoms: constipation, urinary complaints, REM behavior disorder, daytime sleepiness, dementia, falls, freezing of gait, lightheadedness, temperature intolerance, insomnia, and psychosis, significantly more common in late onset Parkinson's disease than in young onset Parkinson's disease, regardless of the duration of the disease. What about response to medications? Again, very important with respect to treatment. Young onset Parkinson's disease folks have a better tolerance to higher doses of levodopa and dopaminergic agonists. Now, I'd like you to remember what dopaminergic agonists are, because this is a special group of medications that act differentially in young onset versus late onset Parkinson's disease. Pramipexole, ropinirole, and the reticotine patch are 3 very common dopaminergic agonists. You do not give high doses of levodopa or dopaminergic agonists to people with late onset Parkinson's disease. Number one, they don't necessarily need it. Number two, there's a lower tolerance to high doses of medications, not just dopaminergic medications, but any medications. You have to be very careful when you start medications in late onset Parkinson's disease or late onset heart disease. Even you start low, you go slow. Dopaminergic agonists unfortunately cause lightheadedness, feet swelling, sudden sleep attacks, and psychosis in people with late onset Parkinson's disease, regardless of the duration. So if you've heard some of my previous lectures, I talk about age and stage of treatment. Young onset age folks tolerate dopaminergic agonists so much better than late onset folks. And I think I already talked about this, but this is again critical. And this is likely because of neuropsychology, neuropathology, as well as our use of dopaminergic agonists. In young onset Parkinson's disease people, primarily impulse control and addictive behaviors are very common with dopaminergic agonists compared to late onset folks. Hypersexuality, gambling, drug use, hobbyism, overeating, excessive shopping, hoarding, and then excessive use of the medication itself. You're using medication because you want it, not necessarily because you need it. It's addiction to levodopa, called dopamine dysregulation syndrome. Universally, I have seen it more common in people with young onset Parkinson's disease. Very important to recognize because I have seen it's broken homes, people have ended up in jail. I've had a couple, 2, 3 people who have become drug addicts, who have come to me saying they were using cocaine when they're not because of these dopaminergic agonists. So now I profile people before I give them dopaminergic agonists, even in young onset. For instance, if someone is morbidly obese, has obstructive sleep apnea, is a long-haul trucker who cannot afford to fall asleep at the wheel, has had prior addiction problems, is extremely hyper type A, has generalized anxiety disorder, is already manic to begin with, and is a gambler, for instance, I do not give dopaminergic agonists. That's how I profile. It is arbitrary. It is not always evidence-based, but that's the art of medicine. You want to minimize harm as much as possible. And impulse control disorders are not very common in late onset Parkinson's disease. How about response to surgical treatment? This is absolutely critical. Late onset Parkinson's disease folks, 60, 70, 80, even 85, 90, are unnecessarily excluded from surgical treatment because of ageism, because of bias. But believe it or not, research studies have shown that surgical treatment for Parkinson's disease has similar salutary outcomes in young, middle, and late onset Parkinson's disease, as long as comorbidities and their surgical risk is well managed. Now, this is important too, because this allows me to choose medication. What about other medical diseases coexisting with Parkinson's disease? Less prevalent in young onset, which is self-explanatory, more prevalent in late onset. Why is that important? Here's an example. Someone has late onset Parkinson's disease, they are on 3 blood pressure medications and their blood pressure is hovering at about 100 systolic, and I give them levodopa. And tomorrow I get a call from the spouse saying, the patient fainted. That's dangerous. What if the patient fainted and hit their head on the toilet seat? That's disastrous. It's catastrophic. So it's very important for me when I look at the patient to look at the other medications and medical comorbidities to say, oh, well, your blood pressure is already hovering over at 100. If I give you levodopa, I'm going to bottom it out. So why don't we just eliminate a couple blood pressure pills, talk to a primary doctor, and then maybe we can start Parkinson's disease medications. So that's how we basically have to treat Parkinson's disease in late onset, is you have to look at other medications and comorbidities, just like you do in young onset Parkinson's disease when you are starting dopaminergic agonists. You want to look at that profile that I just mentioned. We go to genetic mutations. It's a very complex topic, and this could be 3 talks. But I got only 30 minutes, so we're going to talk about the first 3 over here: GBA, LRRK2, Parkin. SNCA is very important, but I just didn't have time to put it all together, and it would have been a very long talk. And these 3 are being researched extensively, as opposed to SNCA in my reading. So we're going to talk about those mutations. Young onset Parkinson's disease folks have a higher a propensity, or rather incidence, of having a genetic cause for Parkinson's than late onset, unless you've got a family history. So someone at 80 comes to me and says, for instance, my mother had Parkinson's disease, my father had Parkinson's disease, my brother has Parkinson's disease, my uncle's had Parkinson's disease. I gotta look for a genetic cause. It doesn't matter if they're 80 years old. So family history becomes important. Now, what's the catch? If someone doesn't know their family history, if they're estranged from their family, or if they're adopted, it doesn't mean that they don't have the family does not have Parkinson's disease. It's just that they don't know about it. But we have to go by what the patients tell us and what the patients know in order to treat them, because we're not really in the era of genotyping everyone. We just don't have the resources to do that. But when someone comes in with young onset Parkinson's disease at age, I just diagnosed someone else, someone who came from Alaska at age 27, and his symptoms had started at age 22. I am definitely going to genotype that person because that person has a genetic Parkinson's disease, even though he does not have a single member in the family with Parkinson's disease. So that's how you nuance it. What about LRRK2? Everyone's heard about LRRK2 due to the MJ Fox trial. Leucine-rich repeat kinase 2, also called LRRK2, is the most common known genetic risk factor for PD. But if you ask research scientists currently, they say that maybe not. It's GBA, which we'll talk about briefly. Seems like there is a tussle between LRRK2 and GBA. They're competing for the most common known genetic risk factors for Parkinson's disease overall. It is important to recognize the risk is not absolute because the penetrance is incomplete. What does that mean? If I carry the gene for LRRK2, there's only a 50% chance of me developing Parkinson's disease if I live to maybe the ripe old age of 85 or whatever. So it is not 100% risk, it's 50%, but that's still important. It is the most common mutation in all of Parkinson's disease, at least per the literature that I've read. 1 to 2% of people have this mutation, and 5% of people who have known family history of Parkinson's disease can harbor this mutation. And how do people with LRRK2 behave? How do you subtype them? If you have this mutation and have Parkinson's disease, the onset can be as early as 32, but as late as 79, and the average age of onset is 60 years. There is usually a family history if you ask, because it's autosomal dominant. What is an autosomal dominant genetic disease? If either one of your parents, either one of my parents have a gene for LRRK2, there's a 50% chance they'll pass it on to me. And so it's only a probability. It could be a 0% chance or a 100% chance, but 50% is average, and that's called an autosomal dominant disease. What is autosomal recessive, which is the other kind? We will see in just a little bit. Sense of smell is supposedly preserved in LRRK2. There's less frequent REM behaviors, acting dreams out at night. There is more lightheadedness, dementia, and hallucinations with LRRK2. There was less tremor, so it is more likely the PIGD kind. Progression of Parkinson's is slower, and when you look at the brain at postmortem, it's a mixed pathology. There's alpha-synuclein, there's tau, there's other proteins as well, so it doesn't have the classic neuropathology of Parkinson's disease at postmortem and when you're looking at the brain post-death. And that becomes important because that tells us that the LRRK2 mutation causes changes in the brain differently than people without without a known genetic cause, which is sporadic Parkinson's disease. How about GBA? So this is that other gene that has really gained prominence at the national stage of Parkinson's disease research over the past 10 to 15 years. It was first determined in Ashkenazi Jews that there's a 10% to 30% chance of developing Parkinson's disease because there's a large number of folks who are Ashkenazi Jews who have the GBA mutation. Eastern Europeans at about 3 to 12%. Now, GBA mutations, the inheritance is a little complex. If you have the mutation only on one chromosome, you're a carrier. You don't have the disease that 2 mutations produce. And the disease that 2 mutations produce is called Gaucher disease. That is completely different from Parkinson's disease. But people with Gaucher disease can also develop Parkinson's disease. So that's important to recognize. 2 mutations, Gaucher disease. 1 mutation when you're a carrier, it increases the risk of Parkinson's disease significantly. And the severity of the Parkinson's disease depends on the mutation, so it's not simple. There are 320 mutations, of which 130 different kinds can increase the risk for Parkinson's disease. If I have a GBA mutation, for instance, there is a higher chance of developing Parkinson's disease at an earlier age of onset, young onset. Family history is likely not present because neither parent is affected, they may not be, and they're just carriers. But it is interesting if both parents are carriers, and they live long enough, they can actually develop Parkinson's disease because being a carrier is a risk. This is one of those autosomal recessive diseases in which you may actually have a family history if you do a good family tree. A REM behavior disorder is supposedly more frequent. There's again more lightheadedness, dementia, hallucinations, just like LARC2. Again, less tremor. Unfortunately, this progresses faster and death is earlier. Does that mean everyone with GBA is going to die fast or progress faster? No. Again, this is just very generic for that group. And the brain examination is quite similar to sporadic Parkinson's disease. So it's a mystery. Why do people with GBA mutations have this different kind of progression and phenotype than people with sporadic Parkinson's disease? Because when you look at the brain after death, it looks very similar to people with sporadic Parkinson's disease. Now, that mystery has not been unraveled yet because not too many brains have come to autopsy yet. What about Parkin? And this is an important mutation. There is research being done, but I don't have data yet to present. This is one of the most common causes of young onset Parkinson's disease. As young as 12 up to 58 years, average onset is about 30. And most commonly it presents in less than 45 years of age. And this is a classical autosomal recessive disease that if you have 2 copies of that faulty gene, there's a 100% chance of developing the disease. It's not just a risk factor, it is actually a mutation. And because of that, if you have one carrier or one mutation, you may not develop the disease at all, unlike GBA. So family history may not be present because if each parent harbors one mutation, they don't develop Parkinson's disease, but each parent could pass on one faulty chromosome each to a child, and that child may develop Parkinson's disease at a young age. People with Parkin mutations, and I know this from personal experience, are extremely sensitive to levodopa. They can go on 100 milligrams of levodopa 3 times a day for 20 years with excellent control. And there is a reason for that the pathology is primarily in the substantia nigra, where you're losing dopamine cells, and it's not widespread. Very commonly, Parkin mutations start with a leg tremor and leg dystonia, which is not common in Parkinson's, sporadic. Usually it's the arm presentation. And because they are so sensitive to levodopa, they can have early motor fluctuations and dyskinesias, even small doses of levodopa. And that's important to know if someone has a Parkin mutation, that I'm not going to give them large doses of medication because they might develop early motor fluctuations and dyskinesias. The progression is quite slow. And here's the kicker. There are no Lewy bodies in the brain. And we thought that Lewy bodies were the hallmark of Parkinson's disease. So scientists and purists are now calling Parkin mutation and not Parkinson's disease. It's a levodopa responsive progressive disease without any Lewy bodies. Now that's important. If Lewy bodies have alpha-synuclein, okay, and someone has Parkin mutation, so maybe alpha-synuclein therapy is not going to work for Parkin. I don't know the answer to that, but that's a hypothesis. If there are no Lewy bodies itself, then maybe that kind of treatment that's reserved for sporadic Parkinson's disease, in which there's a lot of Lewy bodies and alpha-synuclein, may not work for Parkin mutation. We may need something else. And here's the advantage of subtyping. And when you look at the brain, it's primarily dopamine cell loss. There is no widespread damage in the brain, unlike sporadic Parkinson's disease. So how do we utilize this knowledge? Oh, before we go that, SNCA, PINK1, DJ1, ATP, 13A2. I'm not going to bore you with all of these. I'll be happy to give a printout of the slides to you guys so you can read it. But these are 4 other very common genes that cause a young onset Parkinson's disease. And SNCA especially can cause a lot of dementia, can look like Lewy body dementia, and the brain has a lot of Lewy bodies. PINK1, DJ1, ATP, 13A2, very highly rare, very uncommon diseases, but still we gotta look for them if the onset is less than 40 years of age. And the brain may or may not have Lewy bodies. What is the utility of genetic subtyping? Why am I talking incessantly about these genes? Well, it's very important. Already for GBA, there are 5 different clinical trials. And the most wide known right now is the trial of this mucolytic agent ambroxol. Ambroxol is a very small molecule in which you can actually package or the enzyme GBA, which is deficient, and it goes into the brain and basically does it what it is supposed to, because the mutation prevents the production of this particular enzyme. I'm sorry, it doesn't package it, it chaperones it, meaning it shuttles this particular enzyme into the brain. The enzyme by itself doesn't cross into the brain. It's probably the blood-brain barrier is impervious to the molecule of the enzyme, but when combined with Ambroxol, it can make its way into the brain. And so that's being studied currently to see if it can alter the course of people with GBA mutations. LRRK2, we already know there are 5 different clinical trials that are going on around the world. The most widely known is the Denali trial, probably named after the pharmaceutical company. It's at a standstill now, I think, or maybe it has picked up. Last I heard, the molecule was causing pulmonary problems. So they had to stop the trial. Maybe they repurposed the molecule. I don't know the exact state, but if you're interested, you just go to the MJ Fox Foundation Trial Finder and you can look it up. You can see what the stage of the trial is. But that's really exciting. You know, we are actually doing now gene treatment. We're not snipping out the abnormal gene yet, but we are actually altering the downstream pathways of the gene to alter the course of disease. What about biomarkers? And this is actually data-driven, and this is where we need to focus a little bit in the next 2 to 3 years. What are those chemicals in the blood or the cerebrospinal fluid, which is spinal fluid, which can actually subtype Parkinson's disease into its various kinds? Alpha-synuclein, markers of inflammation, and then neuroimaging basically should be a separate section. I think that's incorrect, I'm sorry. It's down here. And then there are a whole bunch of markers. If you are interested in looking at this, just go to PPMI. You can Google PPMI, and there's a ton of information. The PI, primary investigator, is Ken Merrick, M-A-R-E-K, very well known, extremely intelligent, the researcher based upon what he has published, and he just put out an article a couple of weeks ago. I think Stanford is one of the sites of the trial. Then you got neuroimaging. You know, I keep talking about brain examination, and I suppose one obvious question is, well, what use is a brain exam to me? I'm already dead. How are you going to subtype me, right? So brain exam is important. It drives research forward. It helps the field tremendously. If we didn't have the postmortem brain exam, then we wouldn't really know what the pathological subtype is. So I'm a huge proponent for brain donation. I could talk to it with everybody. I mean, I don't think it's morbid. I've got a driver's license that says I'm a tissue donor or organ donor, and I really feel that everyone should donate their brain. That's just me. Anyway, so tissue is skin, and we can talk about skin biopsies in another talk. It's very interesting how you can actually do a punch biopsy now and send it off, and the lab can tell me if there's alpha-synuclein. I just did it for a patient a week ago. I'm waiting to find out the results because this poor patient has essential tremor. Her DAT scan was equivocal, so we didn't know if she had Parkinson's disease. She could tolerate medication, so I needed a surefire way of determining if she had alpha-synuclein in her body, and now we are doing punch biopsies to determine that. Anyway, so this is something which is going to be center stage for a long time, is data-driven biomarkers, not just whether you got a tremor or you don't have a tremor. All right, so I'm going to conclude because I think I've talked your heads off. So in conclusion, Parkinson's disease is a heterogeneous disease, but subtypes exist. It's important to recognize that. For Parkinson's disease subtyping to be accurate and effective, we all have to participate in scientific research. It's important because if we don't, then research scientists will really not know what subtypes are present. So we all sign up, we all talk to APDA. And Jen can tell you a lot more about that. There is a database in Washington run by Dr. Zabadian. We can give our names to the database, and they have the database which can be utilized by research scientists all across the country and perhaps the world with request. So that's really important. Multiple Parkinson's disease need to be identified and tested, not just tremor, not just no tremor. The blood sampling needs to be done. Cerebral spinal fluid sampling needs to be done. Neuroimaging needs to be done exactly as PPMI. And then research outcomes should be durable and reproducible. This is actually a big problem in scientific research, where group A says, eureka, I found something. And then group B does the same trial and doesn't find it. And that's problematic. And there was a great book, if you can get your hands on it, called Sloppy Science. And it tells, informs the public on what drives research. Unfortunately, capitalism does. Unfortunately, tenure does. Promotions do. So sometimes science becomes really sloppy, but science has got to be reproducible. And that's really important. So what one group determines, another group must be able to assert and be able to reproduce, so the outcome is considered to be durable. And then accurate PD subtyping will improve treatment outcomes, lead to cures, which may be different for different subtype. And this is important. That is precision medicine. That is how we get to precision medicine, is I am in group A. I do not want medicine B. It does not work for me, although I have Parkinson's disease. I am in group B. I cannot take medicine A. It doesn't work for me, so don't give me medicine A. So that's precision medicine. And just stay tuned. I suppose if I have more information, I'll bring it out to you guys. All right, the bird's flown. Thank you. And I saved the best slide for last. Jen is chuckling. I'm sorry.